These are the commonly performed liver function tests: serum alanine aminotransferase, serum aspartic aminotransferase, serum alkaline phosphatase, serum bilirubin, and serum albumin. So, indications of liver function test. Number one is screening for liver disease, identify the nature of liver disease, assess severity and prognosis of liver disease, follow up the course of liver disease. It is a normal bilirubin metabolism. Gestation of RBC, first is heme, protoporphyrin, biliverdin, bilirubin, then come in the circulation, bilirubin albumin complex, then bilirubin, from bilirubin to bilirubin diglucuronide. This is called conjugated bilirubin, bilirubin diglucuronide. Then conjugated bilirubin, and this conjugated bilirubin form urobilinogen. So bilirubin is mostly produced from breakdown of hemoglobin. So heme is equal to iron plus protoporphyrin. Protoporphyrin is first converted to biliverdin, which is then reduced to bilirubin. This is called unconjugated bilirubin, and unconjugated bilirubin is water non-soluble or insoluble in water. Bilirubin albumin complex reaches the liver. Bilirubin is conjugated with glucuronic acid to form bilirubin, monoglucuronide, and diglucuronide. This is called conjugated bilirubin. This is soluble in water. When bilirubin reaches the large intestine, it is converted by bacterial action to a group of compounds known as urobilinogen by the action of bacterial enzyme. Most of the urobilinogen is excreted in feces as urobilin and is responsible for brown coloration of stool. A part of urobilinogen is absorbed into the circulation from where it reaches the liver, is taken by the hepatocyte and is again re-excreted in bile, that is called enterohepatic circulation. A small amount of urobilinogen in circulation escapes clearance by the liver and is excreted in urine. Now, the classification of liver function test. Number one is test that assess excretory function of the liver. Bilirubin in serum and urine and urobilinogen in urine and feces. Number two is test that assess synthetic and metabolic function of liver. Serum protein, serum albumin globulin ratio, P time, and blood ammonia level. Test that assess hepatic injury. Number one is serum alanine aminotransferase or ALT, serum aspartic aminotransferase or AST, serum alkaline phosphatase, serum gamma-glutamyl transferase, and 5' nuclear kinase. Test that assess clearance of exogenous substance by the liver, Brome salting, a special test. Now, serum bilirubin. Normal serum bilirubin is less than 1 milligram per dl. There are two types of bilirubin in plasma, unconjugated and conjugated. Normally, conjugated bilirubin is 10% or less, while unconjugated bilirubin is 90% or more. It is normal. This is because conjugated bilirubin is rapidly secreted into the bile after its formation and removed to the gut. Conjugated bilirubin is composed of bilirubin glucuronide, bilirubin diglucuronide, and delta bilirubin. Delta bilirubin represents bilirubin covalently bound to albumin in circulation. Normally, delta bilirubin is absent or present in very small amount. In cholestasis, proportion of delta bilirubin increase. Unconjugated bilirubin is tightly bound to albumin and is water insoluble. Jaundice or icterus refers to yellow discoloration of skin, sclera, and mucous membranes due to increased level of serum bilirubin. Jaundice becomes clinically evident when serum bilirubin level exceeds 2 mg per dl. There are various methods for classification of jaundice. Number one is according to the main type of bilirubin increase in plasma, predominantly unconjugated hyperbilirubinemia. Indirect or unconjugated bilirubin is more than 85% of total. Number one is hemolysis, resorption of a large hematoma, ineffective erythropoiesis, Gilbert syndrome, physiology jaundice of newborn, and Crigler-Najjar syndrome. Now, second is predominantly conjugated hyperbilirubinemia, means direct or conjugated bilirubin is more than 50% of total bilirubin. Number one is hepatitis, cirrhosis, cholestasis, drugs, toxins, Dubin-Johnson syndrome, and Rotor syndrome. Mixed hyperbilirubinemia, conjugated bilirubin is 20 to 50% of total. It results from viral or alcoholic hepatitis. Number two is according to etiology. Hemolytic, hepatocellular, and obstructive. Hemolytic, the increased rate of red cell destruction causes increased hemoglobin breakdown to bilirubin in reticuloendothelial cell. This exceeds the capacity of conjugation in liver. Excrete bilirubin. Number three is obstructive. Failure of excretion of conjugated bilirubin into the intestine causing its regurgitation in circulation. Number three is according to the site of disease. Pre-hepatic, hepatic, post-hepatic. Pre-hepatic, there is excessive formation of bilirubin exceeding the capacity of the liver to conjugate it for excretion. The type of bilirubin increase in serum is of unconjugated type. Hepatic, in hepatic disease, unconjugated, conjugated, or both are increased. Post-hepatic, this is also called obstructive jaundice, surgical jaundice, or extrahepatic cholestasis. So, number one is according to the main type of bilirubin increase in the plasma, then according to etiology, then according to the site of disease. Now the classification of jaundice according to the site of disease. Pre-hepatic is hemolytic anemia, ineffective erythropoiesis, and resorption of a large hematoma. Hepatic jaundice, predominantly unconjugated hyperbilirubinemia, Gilbert syndrome, Crigler-Najjar syndrome, physiology jaundice of newborn. Predominantly conjugated hyperbilirubinemia, hepatocellular disease, viral hepatitis, toxic hepatitis, alcoholic hepatitis, active cirrhosis. Intrahepatic cholestasis, number one is Dubin-Johnson syndrome, then drugs and primary biliary cirrhosis and primary sclerosing cholangitis. Post-hepatic jaundice, carcinoma of head of pancreas, carcinoma of ampulla of Vater, secondary is in porta-hepatis, gallstone or stricture of common bile duct. These are the cause of post-hepatic jaundice. Test which assess synthetic and metabolic functions of liver. Markers of hepatic synthetic function are serum albumin and prothrombin time. These are the two markers of hepatic synthetic function. Hypoalbuminemia and a prolonged prothrombin time indicate severe functional impairment of the liver. Hypoalbuminemia and prolonged prothrombin time. Concentration of total serum protein in adult is about 5.5 to 8 gram per dl, while that of serum albumin is 3.5 to 5 gram per dl. P-time measures 3 out of 4 vitamin K dependent factors, 2, 7, 10, and is prolonged in hepatocellular disease and in obstructive jaundice. To distinguish between a prolonged P-time due to hepatocellular disease from that due to cholestasis with fat malabsorption, how we will differentiate? P-time is repeated after administration of vitamin K. We will repeat the P-time. Reduction of prolonged P-time occurs in cholestatic liver disease, but not in hepatocellular disease. Severity of liver disease is assessed by serum bilirubin, serum albumin, and prothrombin time. These are the 3 parameters by which we can assess the severity of liver disease. Number 1 is serum bilirubin, number 2 is serum albumin, and number 3 is prothrombin time. Test which assess hepatic injury. Serum enzyme changes in liver disease result from hepatocyte damage and do not indicate hepatic functional capacity. In the investigation of the liver disease, following serum enzymes are measured: serum aspartic aminotransferase or AST or SGOT, AST or SGOT, serum alanine aminotransferase or ALT or SGPT, and serum alkaline phosphatase or ALP, and gamma glutamyl transferase or GGT, and 5' nucleotides. So the enzymes are AST or SGOT, ALT or SGPT, ALP, GGT, and 5' nucleotides. Then serum aminotransferase. Serum aminotransferase are the sensitive markers of acute hepatocellular injury. Most marked elevations of ALT and AST, that is more than 15 times of normal value, are seen in acute viral hepatitis, toxin-induced hepatocellular damage, and centrilobular necrosis due to ischemia. These are the causes of most marked elevation of ALT and AST. Moderate elevation, that is 5 to 15 times, occurs in chronic hepatitis, autoimmune hepatitis, alcoholic hepatitis, acute biliary tract obstruction, and drug-induced hepatitis. Mild elevations, that is 1 to 3 times, are seen in cirrhosis, non-alcoholic steatosis, and cholestasis. Determination of these enzymes are helpful in the differential diagnosis of hepatocellular from cholestatic jaundice. Increase of AST and ALT is much more in hepatocellular jaundice than in cholestatic jaundice. So AST and ALT increase in hepatocellular jaundice than cholestatic jaundice. Typical LFT profile in hepatocellular disease. Marked elevation of AST-ALT, usually more than 500 IU. Mild increase of ALP. This is the typical LFT profile in hepatocellular disease. So in hepatocellular disease, there will be marked elevation of AST and ALT, mild increase of ALP. Typical LFT profile in cholestatic jaundice. Marked elevation of ALP, that is more than 3 times normal, elevation of GGT at 5' ALT, mild or no increase of ALT and AST, and elevation of conjugated bilirubin. So the basic difference is In hepatocellular disease, marked elevation of AST ALT, mild increase ALP. And in cholestatic disease, cholestatic jaundice, there will be marked elevation of ALP, mild or low increase of ALT and AST, just the opposite picture in hepatocellular disease and cholestatic jaundice. So these are the tests of liver function test, and we can differentiate pre-hepatic jaundice, hepatic jaundice, and post-hepatic jaundice. Total bilirubin, normal or increased, here it will be increased. Conjugated bilirubin normal, hepatic and post-hepatic, it will increase. Unconjugated bilirubin normal and increase, in hepatic increase, post-hepatic normal. Urobilirubin normal or increased, in pre-hepatic jaundice, hepatic increased, post-hepatic decreased or negative. Urine color will be normal. Here, hepatic jaundice dark. In post-hepatic also dark. Stool color normal, hepatic jaundice normal or pale, post-hepatic pale. Alkaline phosphatase and alanine transferase normal, here it will be increased. Conjugated bilirubin in urine not present in pre-hepatic jaundice, it will present in hepatic and post-hepatic jaundice. Splenomegaly will present in pre-hepatic hepatic jaundice, post-hepatic jaundice it will absent. So this is how we can differentiate between pre-hepatic jaundice, hepatic jaundice and post-hepatic jaundice on the basis of liver function test. Now the viral hepatitis. So what are the viral virus cause viral hepatitis? Hepatitis A, Hepatitis B, Hepatitis C, Hepatitis D, and Hepatitis E. Hepatitis A belongs to picornavirus group of enterovirus spread by fecal-oral route. Investigations, only one hepatitis A virus antigen has been found. Infected people make an antibody to this antigen, anti-HBs. Anti-HBs is more important in diagnosis as HBs is only present in the blood transiently during the incubation period only. Especially in the stool occurs for only 7 to 14 days after the onset of clinical illness. Anti-HBs of the IgM type is diagnostic of an acute HBs infection. Anti-HBs of the IgM type. Anti-HBs of the IgG type is of no diagnostic value, as HBs infection is common and this antibody persists for years after infection. So, anti-HBs of the IgM type is important here. There is no role of anti-HBs of the IgG type. It can be used as a marker of previous HBs infection which presents indicate immunity to HBs. I mean this anti-HBs of the IgG type. So the markers for hepatitis A viral hepatitis, anti-HBs IgM, anti-HBs IgG. Anti-HBs IgM means acute or recent infection. Anti-HBs IgG means past infection or vaccination. Then hepatitis C virus. This is caused by an RNA flavivirus. Acute symptomatic infection with hepatitis C is rare. Most individuals are unaware of when they become infected, only identified when they develop chronic liver disease. Investigations, the HCV contains several antigens that give rise to antibodies in an infected person, and these are used in diagnosis. It may take 6 to 12 weeks for antibodies to appear in the blood following acute infection. Hepatitis C RNA can be identified in the blood as early as 2 to 4 weeks after infection. Active infection is confirmed by the presence of serum hepatitis C RNA in anyone who is antibody positive. So markers anti-HCV, HCV RNA we can detect by PCR. Now the most important virus is Hepatitis B virus. Hepatitis B virus is a core containing DNA. It is a DNA virus. Hepatitis B is one of the most common cause of chronic liver disease and hepatocellular carcinoma worldwide. May cause an acute viral hepatitis. Acute infection is often asymptomatic, particularly when acquired at birth. Investigations for detection of hepatitis B. HBV contains several antigens to which infected person can make immune response. These antigens and their antibodies are important in identifying HBV infection. Although the widespread availability of polymerase chain reaction or PCR technique to measure viral DNA levels in peripheral blood means that longitudinal monitoring is now also frequently guided by direct assessment of viral load. So we can detect viral DNA levels by PCR or polymerase chain reaction. The first one is hepatitis B surface antigen or HBs antigen. Indicator of active infection and the negative test for HBs antigen makes HBV infection very unlikely. HBs antigen appears in the blood late in the incubation period, but before the prodromal phase of acute type B hepatitis. It may be present for a few days only, disappearing even before jaundice has developed, but usually lasts for 3 to 4 weeks. Can persist up to 5 months. The persistence of HBs antigen for longer than 6 months indicates chronic infection. So the first one is hepatitis B surface antigen. Then anti-HBs, antibody to HBs antigen. Antibody to HBs antigen usually appears after about 3 to 6 months and persists for many years or perhaps permanently. Implies either a previous infection, in which case anti-HBc is usually also present, or previous vaccination, in case anti-HBc is not present. Anti-HBc not present, but only anti-HBs will present. That means it is a case of previous vaccination. Hepatitis B core antigen. Hepatitis B core antigen is not found in the blood. But antibody to it, that is anti-HBc, appears early in the illness and rapidly reaches a high titer. Subside gradually but then persists. Anti-HBc is initially of IgM type, with IgG antibody appearing later. Anti-HBc IgM can sometimes reveal an acute HBV infection when the HBs antigen has disappeared and before anti-HBs has developed. Then HBe antigen, indicator of viral replication. In acute hepatitis B, it may appear only transiently at the outset of the illness. The HBe antigen reflects active replication of the virus in the liver. So HBe antigen is the indicator of viral replication. So markers for hepatitis B, viral hepatitis, HBs antigen, current infection, anti-HBs, immunity, anti-HBc IgM, acute or recent, anti-HBc IgG means past or chronic infection, HBe antigen indicates high infectivity and active replication. Anti-HBe means low infectivity. HBeAg indicates viral load. So we estimate viral load by detection of HBV DNA. Now the natural history of chronic hepatitis B infection. First, normal. Then chronic hepatitis, then minimal inflammation, chronic hepatitis, cirrhosis, and hepatocellular carcinoma. These are the natural history of chronic hepatitis B infection. Now the problem comes. Here it is, HBs antigen present for more than 6 months. HBe antigen present. IgM absent, IgG is present. HBe absent, anti-HBe absent, anti-HBs absent. So, what is the diagnosis? কি এটা বলো chronic active hepatitis B. Presence of HBs antigen in the blood more than 6 months confirm chronic hepatitis B infection. Anti-HBc IgM is negative, but anti-HBc IgG is positive, indicate chronic infection. HBe antigen positive indicate viral replication. So it is chronic active hepatitis B infection. Then second is HBs antigen positive for more than 6 months. IgG present, anti-HBe present. All are negative. So, this is a case of chronic hepatitis B with low infectivity. Why it is low infectivity? Because HBe antigen is negative, but anti-HBe appears. That's why it is low infectivity, or low viral replication, or low infectivity. And HBs positive for more than 6 months. That's why it is chronic infection. Anti-HBc IgG positive, but IgM negative, so it is past exposure. Now, HBs antigen negative, HBe antigen negative, IgM positive, and anti-HBe positive, and anti-HBs positive. This is a case of acute hepatitis B infection in the recovery phase. Why it is a recovery phase? Because anti-HBs positive with anti-HBc IgM positive suggest early recovery phase of acute HBV. HBe antigen negative with HBe positive, anti-HBe positive suggest decline in viral replication. Then only IgM is present, all other negative. So it is a case of acute hepatitis B infection in winter phase. In the winter phase, we will found only IgM, HBs antigen negative and anti-HBs negative, surface antigen has disappeared and protective antibody not yet formed. Anti-HBc IgM positive, key marker of acute infection, especially diagnostic in the winter period. In the winter period, we will found only IgM, anti-HBc IgM. Only anti-HBc IgM positive in the winter period of acute HBV. Then HBs antigen positive, HBe antigen positive, IgM, anti-HBc IgM positive. It is a case of acute active hepatitis B infection with high infectivity phase. Reason: HBs antigen positive, chronic HB infection, anti-HBc IgM positive, acute or recent infection, HBe antigen positive, acute viral replication, and high infectivity. Here HBs antigen negative, anti-HBs positive, HBe antigen negative, anti-HB positive, anti-HBc IgG positive, and HBeAg undetectable. It is a case of resolving hepatitis. Resolving hepatitis B. Why? Because HBs antigen negative means no current infection. Anti-HBs positive means protective immunity is present. Anti-HBc IgG positive indicates past natural infection. HBe antigen negative and HBe positive, anti-HBe positive means low replicative phase. HBeAg undetectable means no active viral replication. Here only anti-HBs positive, all other negative. So it is a case of post-vaccination. Immunity to hepatitis B due to vaccination or post-vaccination immunity. In post-vaccination immunity, only anti-HBs will present. Reason: HBs antigen negative means no current infection. Anti-HBc IgM and IgG negative, no past natural infection. Anti-HBs positive, protective antibodies present. Now the panel for diagnosis of jaundice. Qualities 4, conjugated qualities 0.9, and P time normal, Ag ratio normal. Urobilinogen increased. Color yellow, scarcobilin increased. So, it is a panel chart for hemolytic jaundice. Reasons: unconjugated bilirubin is high, urobilinogen high, SGOT, SGPT normal, bile salt, bile pigment absent. Total bilirubin 8.9, unconjugated bilirubin 3.4, conjugated bilirubin 5.5, and SGPT or ALT 925, SGOT AST 723, ALP 167, urine, bile salt, bile pigment present. So, it is a case of hepatocellular jaundice. Reasons: both conjugated and unconjugated bilirubin is increased, SGPT, SGOT increased, bile salt, bile pigment present, stool color pale. Then total bilirubin 10 milligram. Among this, unconjugated is 1.2, conjugated is 8.8. And here ALP is 427. And bile pigment, bile salt present. P time prolonged. Color, stool color is clay. So it is a case of obstructive jaundice. Why? Mainly conjugated bilirubin increased, bile salt, bile pigment present in urine, urobilinogen decreased, P time prolonged, ALP marked rise.